Post-traumatic stress disorder, commonly known as PTSD, represents one of the most profound ways in which trauma can reshape the human experience. This psychological condition develops following exposure to events that involve actual or threatened death, serious injury, or sexual violence. While the concept of trauma responses has existed throughout human history, once called shell shock or combat fatigue in military contexts, our modern understanding of PTSD as a distinct clinical entity emerged largely from observations of Vietnam War veterans and survivors of sexual assault in the 1970s. Today, PTSD is recognized as a condition that can affect anyone who experiences or witnesses overwhelming traumatic events, from combat veterans and disaster survivors to victims of abuse and first responders. The core symptoms of PTSD cluster into four distinct categories that together create a constellation of distress that can profoundly disrupt daily functioning. Intrusion symptoms represent perhaps the most recognizable aspect of the disorder, manifesting as unwanted memories that push their way into consciousness against the individual's will. These intrusions may take the form of distressing recollections that arise unexpectedly throughout the day, nightmares that disrupt sleep patterns, or flashbacks, intense dissociative episodes where the person feels as if the traumatic event is recurring in the present moment. During these flashbacks, individuals may temporarily lose awareness of their current surroundings, becoming fully immersed in the traumatic memory with all its accompanying sensory and emotional components. To manage the distress of these intrusions, people with PTSD typically develop avoidance behaviors, the second symptom cluster. They may go to extraordinary lengths to avoid external reminders such as people, places, conversations, or activities associated with the trauma. Equally significant is their avoidance of internal reminders, thoughts, feelings, or physical sensations that echo aspects of the traumatic experience. This avoidance, while providing temporary relief, ultimately prevents processing and integration of the traumatic memory, paradoxically maintaining the disorder. Over time, this pattern of avoidance can lead to significant constriction in life activities as more and more situations become linked to the trauma and therefore avoided. The third symptom cluster involves negative alterations in cognition and mood that typically emerge or worsen after the traumatic event. These changes may include persistent negative beliefs about oneself, others, or the world, such as "I am broken" or "no one can be trusted." Many survivors experience persistent negative emotional states including fear, horror, anger, guilt, or shame, while simultaneously finding themselves unable to experience positive emotions such as happiness, satisfaction, or love, a condition sometimes described as emotional numbing. Memory disturbances are also common, with individuals unable to recall important aspects of the traumatic event. Perhaps most heartbreaking is the sense of detachment or estrangement from others that many with PTSD experience, feeling as if they exist behind an invisible wall that separates them from those who haven't shared their traumatic experience. The fourth symptom cluster encompasses alterations in arousal and reactivity. The nervous system of someone with PTSD often operates as if danger were ever present, manifesting in hypervigilance, a state of constant scanning for potential threats, and exaggerated startle responses to unexpected stimuli. This persistent state of physiological arousal can lead to irritability, angry outbursts, self-destructive behavior, and significant sleep disturbances. Concentration difficulties are common as attentional resources remain disproportionately allocated to threat detection rather than everyday tasks. Together, these arousal symptoms create a state of exhausting vigilance that takes an enormous toll on physical and mental well-being. The neurobiological underpinnings of PTSD help explain the persistence of these symptoms. Trauma appears to dysregulate several interconnected brain regions, particularly the amygdala, hippocampus, and prefrontal cortex. The amygdala, our brain's alarm system responsible for detecting threats and initiating fear responses, becomes hyperactive in PTSD. Meanwhile, the prefrontal cortex, which normally regulates emotional responses and contextualizes memories, shows decreased functionality. The hippocampus, crucial for memory processing and distinguishing between past and present contexts, often displays reduced volume in those with chronic PTSD. This neurobiological pattern explains why traumatic memories retain their emotional intensity rather than fading like ordinary memories, and why individuals with PTSD struggle to recognize when they are safe in the present moment rather than in danger, as they were during the trauma. The hypothalamic pituitary adrenal (HPA) axis, our body's primary stress response system, also functions abnormally in PTSD. Rather than the typical pattern of elevated cortisol during acute stress followed by a return to baseline, individuals with PTSD often show chronically lower cortisol levels coupled with heightened sensitivity to stress hormones. This dysregulation helps explain the paradoxical combination of heightened reactivity to stress alongside emotional numbing that characterizes the disorder. These neurobiological changes aren't merely correlates of PTSD but appear to actively maintain the condition's symptoms, creating a self-perpetuating cycle that can be difficult to break without appropriate intervention. Not everyone exposed to trauma develops PTSD. Various risk and protective factors influence vulnerability. Pre-existing factors such as prior trauma exposure, especially during childhood, previous mental health conditions, and certain genetic predispositions increase susceptibility. Women develop PTSD at approximately twice the rate of men, though this difference may reflect both biological vulnerabilities and social factors, including types of trauma exposure and reporting differences. The nature of the traumatic event itself matters significantly. Intentional human-caused traumas such as assault or torture generally carry higher PTSD risk than natural disasters or accidents. Peritraumatic factors, those occurring during and immediately after the trauma, also influence outcomes. The intensity of emotional reactions during the event, dissociation, feeling detached from oneself or one's surroundings, and the presence or absence of social support in the aftermath all significantly impact recovery trajectories. Diagnosis of PTSD requires careful clinical assessment, as many symptoms overlap with other conditions such as depression, anxiety disorders, and substance use disorders. Indeed, comorbidity is the rule rather than the exception, with the majority of individuals with PTSD meeting criteria for at least one additional psychiatric diagnosis. This comorbidity complicates both assessment and treatment planning. Culturally sensitive assessment is particularly important, as cultural factors influence how trauma symptoms are expressed, interpreted, and communicated. In some cultural contexts, somatic complaints may predominate over psychological symptoms, or culture-specific idioms of distress may be used to communicate suffering. Effective diagnosis requires understanding these variations rather than rigidly applying Western symptom criteria. Treatment approaches for PTSD have evolved significantly in recent decades, with several evidence-based interventions now available. Trauma-focused psychotherapies show the strongest empirical support, particularly those that help individuals process traumatic memories and develop more adaptive beliefs about the trauma and its meaning. Cognitive processing therapy helps individuals identify and challenge stuck points, distorted beliefs that develop following traumatic experiences, such as self-blame or beliefs that the world is completely dangerous. Prolonged exposure therapy gradually helps individuals confront trauma-related fears through imaginal exposure, revisiting the trauma memory in a controlled therapeutic setting, and in vivo exposure, facing avoided situations that are realistically safe. Eye movement desensitization and reprocessing, EMDR, incorporates elements of exposure therapy alongside bilateral stimulation, typically guided eye movements, to facilitate processing of traumatic memories. Pharmacological interventions also play an important role in PTSD treatment. Selective serotonin reuptake inhibitors, SSRIs, such as sertraline and paroxetine, are FDA-approved for PTSD and can reduce symptoms across all 4 symptom clusters. Prazosin, an alpha-1 adrenergic antagonist, has shown effectiveness specifically for trauma-related nightmares. While medication can provide significant symptom relief, combining pharmacotherapy with trauma-focused psychotherapy typically yields the best outcomes, addressing both the neurobiological and psychological aspects of the disorder. Regardless of the specific treatment approach, establishing safety and stabilization before engaging in trauma processing work is essential, particularly for those with complex trauma histories. Beyond clinical treatments, recovery from PTSD increasingly emphasizes resilience and post-traumatic growth, the positive psychological changes that can emerge following struggle with highly challenging life circumstances. Many trauma survivors report deeper appreciation for life, enhanced personal strength, recognition of new possibilities, spiritual development, and improved relationships emerging from their recovery journey. These positive transformations don't negate the suffering caused by trauma, but represent the remarkable human capacity to derive meaning from even the most difficult experiences. Supporting this capacity for growth requires moving beyond symptom reduction to fostering environments where survivors can rebuild a sense of safety, connection, and empowerment. The COVID-19 pandemic has brought renewed attention to trauma and PTSD, with healthcare workers, COVID-19 survivors, bereaved family members, and those experiencing pandemic-related hardships all facing potentially traumatic stressors. Early intervention through psychological first aid and trauma-informed approaches may help prevent the development of chronic PTSD in vulnerable populations. The pandemic has also accelerated the development and implementation of telehealth services for trauma treatment, potentially improving access for underserved populations while raising important questions about the delivery of trauma-focused therapies in virtual environments. As research advances, several promising directions emerge for improving PTSD prevention and treatment. Neuroscience-informed interventions targeting specific brain mechanisms disrupted in PTSD show potential for enhancing treatment efficacy. Cultural adaptations of evidence-based treatments improve their relevance and effectiveness across diverse populations. Implementation science addresses the gap between effective treatments developed in research settings and their application in real-world contexts, particularly in resource-limited environments. Each of these directions reflects a growing recognition that addressing PTSD requires comprehensive approaches that integrate our understanding of brain, mind, body, and social context. The journey through PTSD, from its development following trauma exposure to the possibilities for recovery and growth, reflects the profound impact traumatic experiences can have on human functioning and the remarkable capacity for healing inherent in the human spirit. With continued advances in understanding and treating this condition, we move closer to a world where trauma's impact can be mitigated and where those affected by PTSD can find not just relief from suffering but pathways to renewed meaning, connection, and purpose in their lives.